My name is Kinga Kisko. I'm a geriatric medicine physician for the Valley Health System in New Jersey, as well as the assistant clinical professor at the Department of Geriatrics and Palliative Medicine at Mount Sinai. And I'm doing this talk with Dr. Takeshi Yumura, who's an assistant clinical professor at Mount Sinai for geriatrics and palliative medicine, like myself, a good colleague. And this particular topic is symptom management II, and by II, we mean this is non-pain symptoms geared for geriatric medicine physicians and palliative medicine physicians. I will be covering xerostomia, pruritus, and hiccups. Following my section, Dr. Yumura will be speaking about malignant bowel obstructions and fatigue. Just to start, we have no financial disclosures. And the objectives of our session are essentially, by the end of the session, you are able to review the prevalence, pathophysiology of the symptoms above, the xerostomia, pruritus, hiccups, small bowel obstruction, fatigue. Recognize, be comfortable with some of the common causes, because that's really key when you're managing these symptoms, is what is trying to ascertain what is causing them and how you're going to target the treatment and therapy. Are there any diagnostic tests that you need to perform? And be able to be familiar with the evidence-based management strategies. There are considerations that are unique to frail older adults or frail adults in general, which I'm also going to point out in my slides. So starting with general principles, always, when you see your patient for any sort of consult or any bedside encounter, of course, we all know we have to perform a thorough history and physical examination. This is what's going to cue you in and guide you as to how you're going to, go ahead and target these symptoms, because we do tailor treatment to cause, and that treatment has to be also tailored to the patient's values and goals. So shared decision-making is really important. What is important to someone matters, especially with medications that may have maybe sedating properties, and something like wakefulness is really important to someone. So you may not, use medications that have those side effects. So always sort of know and practice shared decision-making and reassess frequently. And that reassessment is important both for the ability to ascertain the efficacy of your treatment, but also if your patients are developing any side effects. So on to xerostomia, a very common topic both in geriatric medicine and palliative medicine. Anywhere from up to 40%, probably more, right, of older adults will complain of xerostomia. And that could just be normal, associated with normal, physiology of normal aging. And also when it comes to palliative medicine populations, folks are at very high risk, especially if they have had radiation for, head and neck cancers. People that are in the intensive care unit in general, like let's say those patients are critically ill, they might be NPO, they might be getting aggressive diuresis, are on ventilators, and patients that are at the end of life and are unable to, weaken and cannot close their mouths. Medications are often very common culprits for xerostomia, ones with high cholinergic burden, and some antidepressants are included in that because of that anticholinergic burden. Antihypertensive, especially ones with diuretic properties, and opioids. In all the research studies looking into xerostomia, thirst is a surrogate marker. And so this is something that you may notice in your reading, is how researchers ascertain the degree of xerostomia, and they ask about thirst. And there's a really large clinical impact, because whether it's from mucosal irritation and mucositis, we know that mucositis is very painful, but it can cause fissures and ulcerations and infections. And those oral infections downstream can lead to aspiration events and aspiration pneumonias, especially in frail folks. With feeding difficulty, changes in taste, changing in swallowing, that can lead ultimately to nutritional impairments and medication absorption, especially sublingual medications. denture-related problems and cavities, right? So it can lead to dental cavities. We know that saliva is really important with the pH balance of the mouth, and the more acidic the environment of your mouth, the more likely you are to get cavities. And of course, speech impairment, limited communication, and the way that we're able to, pronounce our diction, right, is really important, and it's compromised with dry mouth. So a little bit on pathophysiology. So as I mentioned before, normal function will maintain oral pH, and that pH is important for a lot of reasons. And a big one of those reasons is antimicrobial defense. Also lubrication, digestion of foods. We start some of digestion of carbohydrates in the mouth. Also saliva and salivary secretion also signals our GI system down the line that food is coming. Some mechanisms of impaired salivary function, I want to, again, call attention to the muscarinic blockade associated with medications. And so that used to be and continues to be one of the first parts of the chart that I review before seeing a patient is their medication list. Radiation therapy, chemotherapy can lead to fibrosis, gland destruction. When people are in the intensive care unit, they're oftentimes restricted on fluids, given medications that are, diuresing them, their mouth breathing, they're on ventilators, unable to close their mouths. And so their mouths get very dry. And there are a lot of comorbidities. You can think of, like, for example, Sjogren's syndrome, right? Like all these things to consider if people that are talking and explaining to you that they're having xerostomia. And older adults, again, are particularly at risk. There's this cumulative xerogenic load associated with polypharmacy. And when it comes to frailty and folks are weaker, are unable to get to even their food sources, and when it comes to even ambulation, right? Or and there's perception and baseline dehydration can oftentimes occur. And so keeping that in mind, especially on hot summer days. Management, the non-pharmacologic management, and this is especially for folks that have frailty, frequent sips of water. And that has been actually in studies observed to be more effective than chewing ice. So small sips of water, I'll tell even patients sometimes, especially ones where I'm worried for aspiration, is even if I have to use a little bit of water on a spoon. Another thing that palliates thirst very well is cold water. So we know, there must be like chemoreceptors there as well in the mouth. A big reason why we don't crave a hot drink on a hot summer day. Sugar-free gum and lozenges work great. Humidifiers, right? Sometimes I would put, like, especially for some of the patients of palliative medicine unit, even putting like a tent, at the base of somebody's face to be able to receive humidified air if they can no longer close their mouth. Something that you may have seen on boards or also in your reading or in research, the ICU bundles. These have actually been studies that looked into the impact of treating xerostomia and how efficacious that sensation of thirst and xerostomia is in patients that are in the ICU on ventilators. It has been found that oral care with soft swabs, saline rinses, and avoidance of alcohol rinses. Alcohol rinses can be drying. Another thing that's really important that's not included in the ICU bundle is lip moisture. So lip moisturizers are also very important. Mucositis is something that always comes up as a question. For mucositis, we know saline bicarb rinses cryotherapy can help avoiding irritants in the mouth to help further perpetuate the problem is really key. There are saliva substitutes. You may know biotin. Gelclair is another one that's a mucosal coating agent. If you have intact salivary function, so this will not work for people that have had radiation, or you have to have functional salivary glands for these medicines to work. Pilocarpine, and I put some of the doses, 5 milligrams POTID. Is one of the pharmacologic ways to be able to treat xerostomia. The onset is about 30 minutes, lasts up to 5 hours. And this is why It's a TID dosing, but know that you're going to have these side effects: sweating, flushing, urinary urgency. 7 million 30 milligrams PO-TID. This is longer acting than pilocarpine. When it comes to mucositis, I think what's really important also is to treat mucositis-related pain, right? So this is why we have those viscous lidocaine swish and spells, and even systemic opioids, right? Or if the pain is really, really severe, because that overall impacts the experience of your patients. For frail older adults, like I said before, encourage non-pharmacologic and topicals first, right? So you want to avoid medications that are anticholinergic. Systemic anticholinergic burden will put patients at a higher risk of medication-induced delirium. There are also agents that can cause dizziness and hypotension. So, and like I said before, water sips, they will outperform saliva substitutes. And there's some studies that even showed that ICU oral care bundles, and some of these bundles did include antimicrobials, have been shown to reduce infections in several studies. And that kind of makes sense. Like if you have a dry mouth and the ability for that mouth to be coated with more organisms and bacteria that are harmful, it's really that oral bacteria that we aspirate that can lead to aspiration pneumonias. So that oral care, that good oral care, can decrease aspiration pneumonia. And this is a little bit more on the first bundle. So you have that oral swab, sterile ice cold water spray, and menthol lip moisturizer. And this would have decreased reports of discomfort in the ICU. And this is one of those things where they had used thirst as a surrogate marker for xerostomia. I do have a little bit on mucositis and oral infection risk because this has come up before in questions. It's really important to understand. I have a blurb on that pathophysiology. You do have antimicrobial protein loss and disruption of the mucosal barrier with mucositis. And so, the mouth gets ulcerated. There's a lot of ability for pathogens to then enter. And this is where it is really important to treat for infection, right? So that you become a high risk for oral candidiasis, reactivation of HSV, bacterial infections. Oral care is very important. Some of the risk factors for mucositis and complications of mucositis being infection associated with mucositis. The management is really going to be oral hygiene, soft brush, saline rinses, topical antifungals, and sometimes you may need, and if your patient is able to get systemic antifungals in very severe cases, consider prophylactic and high-risk chemo patients. And again, I have that blurb for frail older adults with xerostomia and mucositis. There's an especially elevated risk for aspiration pneumonia from oral colonization. So you really want to think about those aggressive oral care bundles to improve your patient's outcomes in the hospital. The next topic is pruritus. So a slide on the causes and clinical impact. So just a blurb on acute versus chronic pruritus. So if it's over a month and a half, over 6 weeks, this is chronic pruritus. Less than 6 weeks is acute pruritus, and it's very common. It's common for folks with chronic kidney disease, cholestasis, certain heme malignancies, polycythemia, for example, and opioids, right? A lot of the times patients will complain of having pruritus after getting opioids for pain control. It's really disruptive and can cause insomnia, decreased quality of life. And these are some etiologies to consider. And it's important to keep those in mind because based upon your etiology is how we're going to treat it. So some systemic could be uremic or cholestatic, malignancy-related, some perineoplastic, illness-related, medication-related, neurological conditions, and like neuropathy in general, psychogenic or dermatologic, just having dry skin. And that dry skin, that xerosis, is a lot of people complain of pruritus with dry skin, especially as the seasons change, or also skin stretch, like sudden skin stretch can also cause pruritus of the skin, especially in the belly if you have sudden belly stretch. It's poorly understood pathophysiology overall. I do have some facts and sort of on how some of these sensations are mediated depending on the etiology. For uremic, it's related to toxins, inflammation, opioid receptor imbalance. Cholestatic is bile salt deposition. Hematologic is cytokine-driven mast cell activation. Peripheral and central sensitization, neuropathic pruritus, and aging skin. And then when you have that increased skin barrier fragility, and then on top of that polypharmacy, a lot of folks might then, especially in frailty, scratch the skin due to pruritus, and then maybe on top of that have some edema of the skin, like distal extremities, because of other comorbidities, and that can really introduce skin pathogens or pathogens under your nails and cause cellulitis. So algorithms for management. So again, evaluate and treat reversible causes. This might be optimizing your dialysis regimen if it's, related to uremia, right? Review medications, right? Are there opioids? ACE inhibitors can cause itching. Any new medications that were just started around the time that the symptom became bothersome. Correct dehydration, right? Treat the underlying disease essentially. One of the start points that I put here, and this is, I think, a board pearl, is SSRIs, right? They might have applicability for treatment of pruritus in your palliative patients, even when the cause is undetermined. So that might be like, that SSRIs is something to try if you're like really not sure. Emollients are really important, especially after bathing 2 to 4 times a day, right? Something that is in a nice like tub rather than a squirt, like a squeeze bottle or a pump bottle, has even less of a water content, so can be even more moisturizing. Always recommend this first line, and continue emollients throughout treatment, even if you're using systemic medications. Sometimes menthol, capsaicin can work for itch. Really be considerate of your patient when using those. If there's any open breaks on the skin, or if somebody's extra sensitive, the menthol may distract somebody from the itch, and then they might have, there might be less of that itch sensation. But if there's open skin or any skin breaks or ulcerations, then it can cause pain. And if in absolutely refractory cases, you might need to refer to dermatology for UVB phototherapy. As far as medications, it's again tailored by etiology. If your patient is having uremic pruritus, gabapentin at low doses, I would say, the reason why I say low doses, we start at 100 to 300 milligrams, and this is something also to consider around the time of dialysis, and also to understand that gabapentin is dose-dependent deliriogenic. So this is not going to be obviously for your very frail older adults. And also Lyrica is another one that you might, pregabalin, that you might consider, but always start low and go slow. Cholestyramine for your cholestatic patients is first line at 4 grams daily and titrate. And then the second line would be rifampin, 150 to 300 milligrams of BID. But, think about drug-drug interactions. And naltrexone could be third line. I'm saying naltrexone, and anytime that I'm going to say naltrexone for itch, in this case, with your patients that are potentially also experiencing pain, is that, to not have, and are on opioids for pain, et cetera, to not have a reversal of that opioid-mediated pain relief, which is why this is like lower line. You really want to make sure that you're not making other symptoms worse. For neuropathic or just like unknown is when we think about SSRIs. I have mirtazapine here because what you'll see in studies, so depending on your patient population, if they're able to safely take mirtazapine, and mirtazapine also has some antihistamine properties. That said, a lot of the times antihistamines are not going to be helpful, especially for chronic cases. So even if if you can try a trial for opioid-induced pruritus, you can try antihistamine or low-dose naltrexone, but this is the time when you might be going to an SSRI. And some of that opioid-induced pruritus might resolve over time. And caution in older adults, all of these medications. For refractory cases, so again, always, so combination drug therapy may work, but that's really when you're going to be talking about, potentially seeing whether your patients are candidates for any dermatologic interventions. And for older adults, emollients are always first line, and just understand the likelihood of increased delirium and falls with gabapentinoids or sedation with antihistamines as well as delirium. Hiccups. Hiccups can be distressing, potentially debilitating. It is a pretty frequent symptom. I've actually been consulted on for my palliative care consult services. And there can be really disruptive to quality of life, eating, drinking, sleeping, especially if they've been going on for a very long time. People suffer from insomnia, get tired, and especially if your oral intake is impacted, malnutrition and dehydration of long-term hiccups can occur. If hiccups are over 48 hours, that's persistent hiccups, or intractable, it's over a month. And just to understand that they can be commonly seen in palliative care and for a lot of reasons. But you can see it in malignancy, central nervous system lesions, and metabolic derangements. And here are some of the pathophysiology explanations. It can be either through irritation. I'll have a picture of it in a second, but phrenic nerve irritation, or acid reflux can be causing hiccups. Gastric distension, and again, irritating the diaphragm can be causing hiccups. CNS lesions, impacting, the medullary center. Metabolic derangement, which is why it's always important to first correct any sort of, abnormalities that you see on that CMP. Stress, excitement, smoking, alcohol, all those are GI irritants, which can have an impact on that reflex arc. Steroids are interesting, particularly high-dose steroids, and I'm going to talk about the doses in a moment. We'll learn that steroids are first line a lot of the times for treatment of hiccups or top line, but they can also be a culprit. So really consider your patient, consider the case. And older adults are at risk from GERD, polypharmacy, and frailty. There's an increased aspiration risk in frail older adults who have hiccups. And this is what I spoke about before in terms of that arc, that hiccups reflex arc. You'll see of the phrenic nerves, recurrent laryngeal nerve, intercostal nerves. You can see how distension of any sort of organs just below the diaphragm can also be irritating to the diaphragm. The hiccup center, upper spinal cord, C3 to C5. Management. So breath holding, Valsalva, sipping cold water, vagal maneuvers. I used to teach families on the PCU vagal maneuvers for folks that, like that carotid massage, for example, for folks that had, hiccups and their loved ones wanted to be able to do something and feel like they can help them at bedside when medications were not working. The only FDA-approved medication, top FDA-approved medication for hiccups is chlorpromazine. But understand that this is something, that can be problematic with people that are at risk for delirium. And Haldol. I've used actually both commonly, 1 to 2 milligrams PO IV BID of Haldol. And understand, though, that, you have to consider your patient, the side effect profile of these medications. Metoclopramide, and if these things have not been successful, the dopaminergic drugs is baclofen, 5 milligrams POTID can be tried, followed by gabapentin. Steroids are also can be effective for CNS related hiccups due to tumors, but this is at lower doses, about 4 to 8 milligrams, because once you get to 8 or more of those milligrams, that can be paradoxically responsible for causing hiccups. And with older adults, avoid chlorpromazine with frailty, start low and go slow. So I'm finding the high-yield review for these 3 topics that I've just discussed. Xerostomia is worsened by polypharmacy it's important to be aware of the importance of the ICU bundle. Be also aware that xerostomia and mucositis is an added risk for oral infections. Understand that pruritus is largely non-histaminergic, so just like putting an antihistaminergic medication may likely not be effective. Use your emollients always with your systemic agents, and SSRIs can be trialed if you're really not sure what's causing the pruritus. Hiccups, always try to reverse the causes. Chlorpromazine is going to be your FDA-approved medication for hiccups, but caution older adults. Know that steroids are both a treatment and a cause of hiccups. Dexamethasone can cause hiccups at high doses of over 8 milligrams, but sometimes can be used to treat tumor-related cases. So really read that question very well or consider your patient very closely. Start low, go slow. Frail older adults are vulnerable to delirium, false aspiration. Don't forget that all these things like nutrition, functional support, oral care, they're just as important as any sort of medications that you're going to be using to treating symptoms. Speaking of medications, always review your medications, whether it's chronic medications or new medications that can have properties that are causing your symptom. Well, for some cases, case 1, you're being consulted for management of symptoms for a 7-year-old patient with medical history of primary biliary cholangitis. They endorse intense generalized pruritus. On exam, you notice jaundice and excoriations on their skin. Give you a minute to think about the management. And go ahead, and I'll go ahead and put it. Oops. So cholestyramine, 4 milligrams daily, is a nice choice for this cholestatic type pruritus. You increase this as tolerated, and if inadequate, remember rifampin can be used second line. You can consider sertraline if there are rifampin interactions, and always maintain those emollients 2 to 4 times a day as an adjunct. Our next case, our patient is a 68-year-old with medical history of pancreatic cancer, has had hiccups for 5 days. Due to this, has been unable to eat. On exam, is cachectic, fatigued, but there's no CNS findings. What can we try? They have pancreatic cancer. Maybe they're even getting, chemotherapy, etc. So this is the case where you would try chlorpromazine, 25 milligrams PO/TID. If sedation is problematic, you can switch to baclofen here, TID or gabapentin. And again, prioritize non-drug measures first. Choose the lowest sedation option. You are consulted for a management of persistent hiccups for a 70-year-old male. You note he is on dexamethasone 16 milligrams per day for brain mets. What is the most likely etiology of his symptoms? So the answer is likely the high-dose dexamethasone, right? This is the steroid stimulate the medullary hiccup reflex arc, irritate gastric mucosa. So, risk rises with high-dose dexamethasone if you go over those 8 milligrams per day or equivalent. And then for management, you want to reduce steroid dose if possible. Also, you may want to switch to prednisone or methylprednisolone that's associated with hiccups, and add baclofen or gabapentin if needed. And always weigh benefits of steroid for intracranial pressure control versus hiccup burden for your frail patients.
Hi, everyone. My name is Takeshi Uemura. I'll be covering 2 common high-yield palliative care topics, which are malignant bowel obstruction and fatigue. So I'm going to first cover malignant bowel obstruction. So this is the case. So you are seeing 75-year-old female with history of metastatic ovarian cancer with liver metastasis and also carcinomatosis. And also she has presumed malignant ascites. She presented with constipation, nausea, vomiting, and severe abdominal pain, and imaging showing that she has complete bowel obstruction. You are palliative care consultant in the hospital and then ask for assistance with symptom management. What pharmacological treatments would you recommend? So malignant bowel obstruction is defined as a mechanical or functional obstruction preventing intestinal transit in advanced cancer. Patients typically present with colicky abdominal pain, nausea, vomiting, distension, and inability to pass stool or gas. It's most common in advanced abdominal cancers, such as colon, rectal, ovarian, stomach, pancreatic, bladder, and endometrial. It can occur from tumor invasion, extrinsic compression from the tumor, and also peritoneal carcinomatosis. One important and then both relevant distinction is the partial versus complete obstruction. Partial obstruction typically present with intermittent symptoms, but patient can pass some gas or stool, and also patient may tolerate liquid diet or can take liquid. In comparison, complete obstruction present with persistent vomiting, and there's no stool passing or gas passing, and also patient has severe distension of the abdomen. An obstruction in advanced cancer usually suggests a poor prognosis. Even with palliative surgery, survival is often less than 6 months. Some cases resolve spontaneously, usually within about a week, but recurrences are common. Without resolution, median survival is about 4 to 5 weeks. Poor prognostic factors include ascites, peritoneal carcinomatosis, poor performance scale, and also multiple obstruction history. So now we're going to talk about pharmacological management of malignant bowel obstruction. For pain, we typically use opioids since patient won't be able to take PO, so it needs to be IV or subcutaneous, typically hydromorphone or morphine. You can also add an anticholinergic agent if there is colicky cramping or distension. Glycopyrrolate is preferred since it doesn't cross the blood-brain barrier, so it has less delirium risk. Scopolamine also can work, but it can impose delirium risk because it crosses BBB. For nausea, vomiting, haloperidol is the first-line agent. Historically, and metoclopramide can be used only in partial obstruction. So this is very important point. And it is contraindicated in complete obstruction because it has a prokinetic effect and it can worsen symptoms and even cause perforation in complete obstruction. Orazapine also has good supporting evidence, and it can be even dosed daily. So it's useful for nausea vomiting. Corticosteroid also can be used, and it reduces edema and inflammation, and typically use dexamethasone IV in 8 to 16 milligrams per day. Ondansetron, which is Zofran. We typically use Zofran for nausea in general. However, in malignant bowel obstruction, there is no evidence to support its use, and some guidelines recommend against using them as first line or second line. Same for prochlorperazine as well. To reduce GI secretion and improve comfort, octreotide is the preferred agent. Dosing is typically 50 to 100 microgram subcutaneous every 8 hours, or it can be administered as continuous infusion. It decreased secretion of gastric pancreatic enzymes, decreased peristalsis, and splenic blood flow. There are some mixed study results. However, subgroup analysis showed good results. So guidelines recommend octreotide as first-line agent for inoperable malignant bowel obstruction. In clinical, often octreotide is used as a combination therapy, typically octreotide with anti-dopamine agents and also steroids. H2 blocker and PPI can be also used to reduce GI secretion. So you can use also NG tube to decompress, and it can relieve symptoms, and also sometimes you can keep NPL as well. TPN is not routinely recommended. TPN is the total parenteral nutrition. It's not routinely recommended in patients with limited life expectancy or poor performance status. There's a little impact on survival. Surgery is typically reserved for single site obstruction, good performance status, and minimal ascites or carcinomatosis. Even if it's performed, complications are common, and it can cause even re-obstruction and readmission. Endoscopic stenting are excellent for single site obstruction in approachable sites such as gastric outlet. And then a study showed a high symptom relief rate. So I said NG tube can be used, but it's not long-term solution. So if patient needs long-term NG tube placements or release of gastric distension, bent-in PEG is the option typically. And it relieves nausea, vomiting in about 90% of the patients. And patient can even take oral intake and resume diet without fear of vomiting. However, it is contraindicated in the presence of large amount of ascites because the PEG placement cannot be done with the ascites. This is very PTE egg, is also available in limited number of institutions. And actually it can be performed in patients with even large amount of ascites because it is inserted through esophagus instead of gastric. Now we're going to move on to fatigue. Your 67-year-old male patient with advanced cancer presents to your clinic and says, "Doc, I feel fatigued and weak, like I have no energy and I cannot concentrate. What do you recommend?" Fatigue in palliative care is very common and also underreported. Fatigue is defined as a persistent sense of tiredness, which is not routinely relieved by rest, and it interferes with daily functioning. It affects up to 80 to 90% of the patients with advanced cancer and other serious illness. Despite this, only half of patients ever discuss it with their providers. Fatigue is typically multifactorial. Common causes include the following: cancer and treatment-related factors, malnutrition and cachexia, medications such as benzo, opioid, psychiatric conditions such as depression, anxiety, hypoxemia and anemia, organ dysfunction, including heart failure, liver failure, kidney failure, respiratory failure, electrolyte abnormalities, and sleep disturbances. So it is important to identify reversible causes and then treat it if it's possible. First-line management for fatigue is a non-pharmacological approach, and strongest evidence is the physical exercise. And it improves fatigue, mobility, and quality of life. And the strongest evidence come from aerobic exercise. And resistance training may be helpful in cancers where cachexia is present. Energy restoration exercise such as yoga has been shown to be helpful in patients with breast cancer and end-stage renal disease. Psychoeducation and CBT can be helpful as well. And acupuncture, Tai Chi, and good sleep hygiene can help as well. But the bottom line here is exercise has the best robust evidence and should be your first choice in a board exam. Pharmacological management for fatigue. When medications are used, evidence is modest and benefits are variable. We typically use stimulants. However, again, the evidence is modest and also effect can be modest. And then it works quickly, actually. And then, so if you have questions about pharmacological management in fatigue, methylphenidate should be the first choice. However, modafinil also has been shown to be effective as well as methylphenidate. Recent systematic review showed actually paroxetine also may work well. However, I think in your board exam, methylphenidate should be the first choice. However, you have to be careful with the patient with cardiac disease or cognitive impairment because it can cause arrhythmia and also the delirium. I'm sorry, I'm talking about methylphenidate. You can also use glucocorticoids such as dexamethasone 4 milligrams to 8 milligrams per day. However, long-term use is limited because of side effects, and also evidence is weak and inconsistent. You can consider a short-term trial, which is typically less than 2 weeks, and to see if it works. People sometimes use Megace as well, and it helps with anorexia, cachexia, which contribute to fatigue. However, it has increased risk of DVT and PE and edema and mortality as well. So you have to be very careful when you consider starting. I think that's it. So this is a CME question. So which of the following drugs should not be the first-line agent for medical management for partial malignant bowel obstruction related nausea? Choice A, metoclopramide, B, haloperidol, C, ondansetron, D, olanzapine. So the answer is C, ondansetron. The role of serotonin receptor antagonist for malignant obstruction-related nausea is unclear. Serotonin receptor antagonists like ondansetron are frequently used in anti-emesis in the hospital setting. However, ondansetron targets the serotonin system, which is not the primary mechanism of nausea in malignant bowel obstruction. So dopamine receptor antagonists such as haloperidol are the best first-line treatments for MBL associated with nausea. Metoclopramide also works. However, it has a prokinetic effect, so should only be used in partial obstruction, which is the case actually in this question. So it is fine to be used. Olanzapine, a typical antipsychotic, has been shown to be effective as well in a small randomized clinical trial, so it can be used. Thank you. So these are the reference for malignant bowel obstruction as well as fatigue. Thank you.